All right, let's shift gears and talk about heart failure gone really bad. This is your cardiac ICU patient. How do you take care of this cardiac ICU patient? And remember, if you first get to the CCU, everything looks very, very confusing. There are a lot of drips started. Patients are on tons of monitors. They have Swan-Ganz catheters in, measuring their cardiac output, their preload, and their afterload. I want to give you just in one slide a summary. And it's never going to be complete, but just give you an idea how people actually think about taking care of a patient in the cardiac ICU. Okay, this is a busy slide, but don't worry, we're going to go through every aspect of it. Remember the fine-tuning of the heart that I mentioned in the beginning? And remember all the different ways you can improve cardiac output? This is exactly what we do in the cardiac ICU. Okay, we have those 4 measures. We have our preload, our afterload, our contractility, and the heart rate. And we can improve all 4 of them. We can measure all 4 of them, and we can improve all 4 of them based on the measurement. Measuring preload, afterload, and contractility is possible with a Swan-Ganz catheter. And the Swan-Ganz catheter is out of the scope of this talk. But just believe me, when I give you certain values, this is how we measure it, okay? Okay, let's focus on our preload first. Preload, as I mentioned before, gets measured with a pulmonary capillary wedge pressure. A normal pulmonary capillary wedge pressure is around 10. In pulmonary edema, it's often more than 20 or 25, right? The goal for your pulmonary capillary wedge pressure really depends on the patient, and that's where a lot of expertise comes in. But just in general, you want to have a patient as dry as the cardiac output tolerates. Remember our first graph where we talked about the cardiac output curves? You cannot massively diurese a patient in cardiac shock. You're going to drop the patient's cardiac output, okay? So you have to be very gentle with that. A couple general thoughts about it. If you have a pulmonary capillary wedge pressure more than 20, even in a patient with chronic heart failure who normally depend on a high pulmonary capillary wedge pressure, your wall tension goes up. And with an increased wall tension, you have more ischemia to certain areas, and it's not good for the heart. A pulmonary capillary wedge pressure of 25 or more than 25 is really, really bad sign. You don't want your pulmonary capillary wedge pressure more than 25. All right? So keep those 2 goals into mind. Try to drop it below 20, but be very careful about doing so. So you can manipulate your preload either by giving normal saline boluses and create your own Frank-Starling curve, see whether the patient responds to volume, or diurese and give dialysis if the preload is too high, you need to get volume off. Next wheel that you can turn is the afterload. You measure the systemic vascular resistance and the blood pressure in the cardiac ICU. Your resistance, you can calculate that using sophisticated measures of a Swan-Ganz catheter, and it's about 800 to 1,200. That's your goal. In order to decrease afterload, you have many good measures, and they're outlined here. Okay, you can give a patient nitro spray. If the patient doesn't respond to nitro spray, let's say after 3 sprays every 5 minutes and the patient still didn't drop the blood pressure, you can start a patient on a drip, on a continuous infusion. And how it's normally done in the cardiac ICUs, you start the patient at 5 micrograms per minute and titrate up by 5 micrograms per minute per effect. Okay, so the nursing stuff will do that for you, and you can go up to 400 micrograms per minute. Often patients get headaches with increased nitro doses, so you need to be a little careful about that. In a patient with hypertensive crisis, we use even a more potent medication called nitroprusside. And similar to the nitro, you're going to start at 0.5 microgram per kilogram per minute and titrate that up by 0.5 every 5 minutes per effect. Maximum is 10 micrograms per kilogram per minute. Remember, from your step 1, cyanide toxicity, this is why. Okay, so you don't want to escalate your doses too much. And a great medication, often forgotten, are ACE inhibitors. All right, you don't have to start a continuous infusion. You don't have to put a patient on a drip. You can give the patient ACE inhibitors. And what they normally do in the cardiac ICUs, start a patient on captopril. The big advantage is that captopril is short-acting, so you give it every 6 hours. And the big thing about short-acting medication is that even if it drops your blood pressure, it's out of your system fast. So you don't need to worry about it too much. And once you determine how much captopril is good for the patient, how much captopril improves the patient's cardiac output to a maximum, you're going to convert it to long-acting lisinopril in a 5-to-1 ratio the next day or the day after. Up to our next wheel, contractility, cardiac output or cardiac index. This is what you measure in the ICU. So your cardiac index is just your cardiac output based on the body surface of the patient. And a normal cardiac index is 2.6 to 4.2. The goal in the cardiac ICU is to get the patient above 2.2. And this is where all your vasopressors come into, that you hear about a lot and that are often quite confusing. Okay, those are those medications. Their drips, they have certain rates based on the kilogram, on the weight of a patient. There's the butamine and dopamine, and starting doses are listed here, how you start the doses, and then you titrate them up to effect. A little different works milrinone. It's a phosphodiesterase inhibitor, and you normally give a bolus and then again titrate up to effect. And norepinephrine is our general medication for blood pressure control that you will hear a lot about in your septic shock lecture. And this is a range of dose and also dosed based on effect. Right? And lastly, if those medications can't help to increase cardiac output, there comes something called an intra-aortic balloon pump or left ventricular assist devices that are out of the scope of this talk. But this is also a way to mechanically increase cardiac output. A couple of words about why we love milrinone. Milrinone is less arrhythmogenic. So the big problem with dobutamine and dopamine is that they are arrhythmogenic. They increase arrhythmias in patients. And often patients are in cardiac shock because they had an MI, they had an ischemic event. And in those ischemic events, you're going to have area of scarring in your heart. And those area of scarring are going to have electricity circuits running around, so increasing your arrhythmogenic potential in your heart. So you don't want to make that worse with giving them inotropes that make you more arrhythmogenic. So milrinone doesn't do that, at least not to the same extent. That's why it's often very popular. It also has a vasodilatory effect, which helps decreasing the resistance in your pulmonary circuit. And norepinephrine actually has been shown to have a mortality benefit over dobutamine in cardiac shock. That's why it's more often used now than dobutamine. The last wheel is, again, the heart rate and rhythm, and we're going to talk a lot more about that in our tachycardia topic, but just keep that in mind that this is a wheel that you can manipulate as well. So just to summarize it, in the CCU, you have 4 different wheels that you can manipulate. You have the preload, you have afterload, you have contractility, and you have heart rate. And we measure all of that with the Swan-Ganz catheter. Last topic in the treatment section, how to prevent readmission. How do I make sure my patient, after I did all those great things, gave him diuretics, patient was in CCU, and is finally discharged, how do I make sure this patient doesn't come back next month with exactly the same problem? There are 2 parts of the deal. There's a doctor's part of the deal and a patient's part of the deal. Let's start with the doctor's part of the deal first. All right? If you have a patient, you want to make sure that at discharge, the patient is at optimum heart failure therapy. To make sure the patient gets all the heart failure therapy that have been studied to have a mortality benefit for the patient. Also, you want to make sure the patient has optimal coronary artery disease therapy, if there was any area of ischemia that it was revascularized. Okay, we think about that in stage therapy. It's based on the New York Heart Association stage, and there are 2 different broad categories: medications that have been shown to have a mortality benefit, medications that have a symptomatic benefit. So here are your diuretics. Remember, your diuretics, the mainstay of treatment on the medicine ward, has only a symptomatic benefit. It will not give your patient a a mortality benefit, similar digitalis, right? So keep in mind, just giving a patient diuretic during the admission is not going to decrease the mortality of this patient. What does decrease the mortality? ACE inhibitors or ARBs, if ACE inhibitors are not tolerated. Beta blockers, aldosterone antagonists are really helpful. And hydralazine in African Americans have been shown to all have a mortality benefit. Also, two therapies that have nothing to do with medications but are devices have been shown to have a mortality benefit. There is the biventricular pacing and there are AICDs. So devices, we have AICD. The main indication for AICD is a patient with a low EF who had an MI and is 40 days after the MI. Why 40 days? We want to make sure that the patient's cardiac output didn't improve after the MI, because it often does. So, and in heart failure class 2 and 3. Class 2 medication is if the patient didn't have an MI, but has cardiomyopathy because of another reason with an EF of 35%. A cardiac resynchronization therapy or a biventricular pacer, again, class 1 indication is a low EF, a left bundle, and a QRS more than 150. This is new. It was more than 120 before. Now it's more than 150. And importantly, starts with New York Heart Association class 2. So it starts quite early here. Keep that in mind. It's a new indication as well. Class 2 indication would be also low EF, but the old kind of QRS that we're all more familiar with, more than 120, and was a newer class of 3. Apart from the doctor's part of the deal, comes the patient's part of the deal. All right? So you want to spend a lot of time at the bedside teaching your patient how important it is to be compliant with medication, how important salt-reduced diet is, and to follow a daily weight schedule. And if your patients are smart and able to do that, you can use daily weights to come up with a flexible diuretic dosing schedule. Last section is assessment and plan. How do you write it up? If I have a patient with CHF exacerbation or cardiac shock, I try to divide it in 3 issues. 1 is a pump. 2nd is ischemia. And 3rd are rhythm problems. And I divide it into those 3 categories because it gives me a clear outline how to think about this patient. For the pump, I want to mention what kind of cardiomyopathy does a patient have. In this case, ischemic. Is it a heart failure with reduced ejection fraction or a heart failure with preserved ejection fraction, so a diastolic heart failure? What is the last EF? And what was the exacerbation most likely precipitated by? It makes a difference whether it's medication non-compliance or ischemia, a heart attack. Then I think about 3 issues: preload, afterload, contractility, just like we did in all the previous slides. For preload, I want to establish what is the estimated dry weight, what is the admission weight. So in this patient, the patient is about 20 pounds above the dry weight, and the current weight is 130. So I still have 10 pounds to go. The diuretics dose that I use, I want to make sure I order strict intake and output and daily weights. I want to make sure I actively check electrolytes while diuresing. For afterload, I want to determine, is the patient hypertensive? What do I do? Today, captopril, tomorrow, converted to lisinopril. Last issue is contractility. This is mainly in CCU, and the CCU should mention all the vasopressors that you use in order to improve contractility, as well as if there are any intra-aortic balloon pumps. Second issue is the ischemia. You want to mention, did this patient have a STEMI or an NSTEMI? What was the intervention at that time? And does the patient currently have any evidence of ischemia? Want to make sure the patient is on the right antiplatelet therapy, on a statin, if a patient had a heart attack or a cardiac event. And for rhythm, want to make sure this patient is not an AFib with RVR, and you want to mention good plan for rate and rhythm control, as well of anticoagulation if the patient is an AFib. And we're going to talk a lot about that in the atrial fibrillation topic. So remember, divide your topic into pump, ischemia, and rhythm. And that's how you're going to present it to the medical team during rounds as well. Take-home points. If your resident tells you to eyeball the patient, think about, is this patient warm and wet or cold and wet? Warm and wet, goes to the ward, cold and wet goes to the cardiac ICU. If you diagnose CHF, make sure you pay particular attention to the S3 and JVD, congestion X-ray, and use the BMP to rule out CHF, not to rule it in. Make sure you look at all the different potential causes, because they are all, or at least most of them, are fixable. Look at preload. Is this patient medication non-compliant? Does he have diet issues? Afterload. Is there significant hypertension in this patient? Contractility. Don't miss an MI. That's embarrassing if you miss an MI in a patient with a CHF exacerbation. And heart rate. Make sure this patient is not in atrial fibrillation. Treatment. Think about all those causes that can cause heart failure and optimize them. Optimize preload, afterload, contractility, heart rate. For warm and wet, main therapy is diuresis and can be done on the floor. For cold and wet, vasopressors in order to increase cardiac output will be done in the cardiac ICU. And for your assessment and plan, split up your assessment and plan into pump, ischemia, and rhythm. And for pump, mention all three: preload, afterload, contractility. Okay, lastly, there are some links, useful links. There's a primer that summarizes everything nicely by Vladimir Klinsky. There's a sample CHF case, and there's a sample case for cardiac shock by Joseph Brennan, who is director of the cardiac ICU. There are two great papers that I want to recommend. One is the rational clinical exam. That's where I got all the likelihood ratios from. And the New England Journal Paradigm Shifts in Heart Failure Therapy is really useful. It summarizes all the different studies that showed whether a treatment has either a mortality or a symptomatic benefit. Okay, so thanks a lot for listening in. Hope you had some fun and learned something, and you stick with the Yale20. Thanks a lot. Bye.